Welcome, everyone. Thank you for coming along to tonight's research conversations. This night, we're doing something a little bit different. We're actually getting people to present their research, people who are currently or have finished either a PhD or an honours degree. And we thought this would be a great opportunity to do things a little bit different and hear about some current research that's occurring within medical radiation sciences. So we've got people also from different fields. So we have representation from RT, nuclear medicine, diagnostic radiography, and ultrasound as well. So we try to touch across all the modalities. So research conversations is something that we try to offer around about 4 times a year, and it's hosted by the Australian New Zealand Medical Radiations Research Network. So thanks for coming along, and I hope you enjoy the presentations. Pippa, we're going to start with you. Do you mind doing a bit of a self-introduction?
Yeah, sure. Thank you so much, Peter. Hi, everyone. I am Pippa. I have recently joined the University of Auckland team, and I'm going to just share with you some of the PhD findings that we had. 10 minutes is a really short amount of time, so I'm going to try not to speed through it too fast. But yeah, I just want to share what we found and where we're planning on going from here. So ultimately, we sort of looked at PET-CT imaging of hypoxia in patients diagnosed with tuberculosis. And I just want to give you a little bit of an intro just to tell you how we got to the point that we actually did. And then I'm going to just share some of the main findings, not of the whole study because of time, but just some of the interesting things that we came across. And we know tuberculosis is a worldwide health concern, primarily in developing and underdeveloped countries. And the core of most mature TB granulomas are necrotic and hypoxic. So that means if there's hypoxia in these granulomas, it normally leads to dormancy and ultimately disease progression, because those hypoxic cells prevent the microorganism in the tuberculosis to respond to the standard TB treatment regimen. So if oxygen content in these TB lesions drops, then there appears to be sort of a reduced susceptibility to the standard TB regimen, but an increased susceptibility to nitro-imidazole drugs. So the aim of our whole study was to try and assess this hypoxic load in the tuberculosis lesions in the patients in order to determine whether we could select potential non-responders in order to refine their tuberculosis therapy. Because if we look into host-directed therapies, it leads to much shorter treatment durations with less burden on the health system. So that was the aim of our project. Now, if we take a look at the hypoxic uptake, nitro-imidazoles or hypoxia-seeking tracers have been validated for use in oncology. And with the development of our benchtop gallium generators, it means that we have a readily available positron emission or positron emitter radiopharmaceutical that we can now use in order to image in-house, in department, and it's more readily available than our cyclotron radionuclides or radiopharmaceuticals. So by being able to link our gallium-68 to the nitro-imidazole, we ultimately wanted to see, could we detect this hypoxia in the tuberculosis lesions? So the compounds containing nitro-imidazoles are reduced and retained exclusively in hypoxic cells where they're irreversibly trapped. So in normoxic tissue, these nitro-imidazoles would diffuse out. However, they are trapped in the hypoxic cells, and that is what we tried to image. So these are basically the focus areas that we looked at. Initially, we just sort of conducted a review to determine how and where we could access the gallium-68 nitro-imidazoles, and that then we published in the Annals of Nuclear Medicine. So I'm not going to talk too much onto that, but I'm going to focus on the proof of concept study and also a case series to show you some of the images we obtained. And then I'm going to jump across to looking at, we had 2 readers assessing the images on 2 different software systems, and I'd just like to share some of those findings with you as well. In terms of our methods, we recruited patients from the local tuberculosis clinic for the study, and we had some patients undergoing early and delayed imaging, so 2 separate time points on the same day. We also had patients undergoing a baseline and a follow-up PET-CT. And then some cases were also scanned at dual time points. So we had early imaging, delayed imaging, or baseline and follow-up. So some patients underwent different things for different purposes. We labeled the gallium nitromedazole in-house. And then in terms of the imaging and the processing, we didn't use any intravenous or oral contrast media. And on the images post-processing, we drew 10 millimeter circular regions of interest. And this was in areas of uptake that we saw or in areas of pathology that were identified on the CT scan. And then we used the semi-quantitative measures, the standard uptake values, to calculate the lesion to muscle ratio and also the lesion to blood ratio. So we used the sternocleidomastoid muscle as a normoxic reference tissue, and then we had the aorta and the left ventricle being our blood surrogate regions. And the lesions were classified as being hypoxic if they had a lesion to muscle ratio greater than 1. This was all assessed on 2 different software systems by 2 independent readers. So the main part of the study where we wanted to just describe and quantify the uptake in these lesions, we saw uptake in the nodules, in cavitation, in areas of consolidation, and also in effusions linked to tuberculosis. In general, the radiopharmaceutical had a high vascular activity. The kidneys, bladder, liver, and colon were the excretory routes, and this was expected from the preclinical data. And then we had low-grade uptake across most or all of the lesions. All the patients had more than 1 lesion that we looked at, and the upper lobes were most frequently affected. Some lesions that were seen on the CT study did not show any hypoxic uptake. So this is then what we did. We classified or quantified the uptake according to the lesion type. We anticipated the lesion to muscle ratios to be greater in the cavities, especially in the consolidation around the cavities, but this wasn't the case. The nodules and the effusions actually had the highest lesion to muscle ratios. We are not sure why, but that's just what we found. So in terms of the images, this is something that we would have seen. As you can see that it's a very low grade uptake in comparison to the blood. And this was consistent across all patients. And then in terms of the case series, I wanted to just show you, we compared the uptake pattern of the nitromedazole to fluorine-18-FDG, which is the most commonly used radiopharmaceutical in PET imaging. So we had 6 patients who underwent this series of images. 1 patient was later confirmed to be Mycobacterium kansasi, but we decided to keep that patient in the set of results because the treatment for the kansasi versus the Mycobacterium tuberculosis are very similar. So we didn't think it would affect the uptake too much. This was the first patient that we scanned, and it was a 60-year-old lady who was newly diagnosed with tuberculosis, and she had fibrocavitatory apical disease bilaterally. On this image, you can only see it on the one side. So we saw the uptake in the area of consolidation around the cavity, which was pretty promising, but this patient was lost to follow-up because it was the start of the pandemic in South Africa, so we could not follow her up. We're unsure of her treatment response. The second patient was a 52-year-old, also a newly diagnosed patient. So the top row of images is the baseline scan, and then on the follow-up scan underneath that, you can see how the hypoxia has shifted. Even though there has been slight response to therapy, the lesion to muscle ratios were greater on the follow-up scan than it was on the baseline, indicating a greater hypoxic load. This was similar to this case. This patient actually had a very good response to therapy, but despite the apparent morphologic response to therapy, the lesion to muscle ratios were again much larger on the follow-up compared to the baseline scan. Then when we compared, these were the gallium to gallium comparisons, but when we compared the nitromedazole uptake to the fluorine-18-FDG, we actually saw areas of concordance and also discordance. So this patient was an extrapulmonary tuberculosis patient, and we can see that there are areas of concordance and discordance, and that we expected because the lymphatics are thought to be a portal of disease spread in tuberculosis. Then this final patient in the case series, he had the FDG at baseline, and then he had the nitromedazole for comparison, and then 6 months later, another nitromedazole scan. You'll see that this timeline is a lot longer compared to the previous patients. We try to catch the patients within a month after starting tuberculosis treatment. However, with the pandemic, this patient's scan had to be delayed. He couldn't join us before. Now, when we compare the nitro-imidazole to the FDG uptake, you can see that it follows a similar trend or similar pattern. The lesions with high FDG uptake also had the greatest hypoxic load. And that was another interesting finding, but not all lesions that were FDG avid were also hypoxic. So this basically just told us that we could use these nitro-imidazoles in tuberculosis, and we could use it to quantify the hypoxic load as a potential identifier for patients who would not necessarily respond to the standard TB treatment regimen. Now I am watching the time, so I'm just going to briefly run through the inter-reader agreement on the software programs. So what we wanted to do is basically see how reproducible were these results on two different systems and between two different readers. So we had the Siemens and we had the Osirix, and we had 182 regions of interest analyzed by each reader on each system. And what I just want to point out in these slides is that if we looked at reader 1 versus reader 2 on system 1, there were no differences. Again, with system 2, reader 1 versus reader 2, no significant differences. But when we compared reader 1 on system 1 and 2, there were differences. Now we know that there's many factors that can affect SUV measurements, including extravasation, inaccurate radiopharmaceutical dose, or the size and the placement of the regions of interest. There's just many things that can affect these SUVs, but it's really important in PET-CT imaging when patients come for follow-up that we're able to produce reproducible results. And it needs to be looked into and monitored if you're having patients being scanned on different scanners, or if the post-processing is done on different systems, because there might be differences that you come across. So basically, in summary, this whole study came about by us translating the role of hypoxia PET-CT from oncology, bringing it across to infection and inflammation imaging in tuberculosis. We saw the low-grade uptake. There was persistent uptake over time in patients and also between patients. And this uptake was not predictable. There was good inter-reader agreement. However, there was poor inter-system agreement in those comparisons that we did. What was so special about the study for us? It was the first time we were able to label the nitro-imidazole in-house. And it was the first time it's been used in an infectious disease such as tuberculosis. And it's basically the first description that we're aware of that quantified this hypoxic uptake using PET-CT images. So where to from here? We would like to fix up the tracer reconstitution, that we get improved lesion to muscle and lesion to blood ratios. And we would like to also explore if this would be a prognostical predictor for patients who would not respond to therapy. We'd like to look at the application in multi-drug resistant and extremely drug resistant TB because it's thought that these are more hypoxic. And also kinetic modeling with a whole body PET-CT would give us great information about this dynamic nature of the hypoxia in the TB lesions. And then finally, we'd like to look at the effect of treatment on hypoxic uptake because all our patients were on the tuberculosis treatment when they came for the scans. So that is my story. Thank you to my supervisors, my co-supervisors, and of course, my new family at the Department of Anatomy and Medical Imaging. And I'm happy to take any questions afterwards. So thanks,
Thank you
Peter.
so much, Philippa. Appreciate that. Rachel, do you mind sharing your screen? So Rachel is a PhD student at Monash University. She works across a number of different departments at Westmead Hospital and Blacktown. And her presentation title is on the screen. Thank you, Rachel.
Thank you, Peter. Thanks for the introduction. Today, I'm really happy to share with you my talk I gave at the Cairns conference on what hooks Australian radiation therapists to participate in research, motivators and enablers. What is it that drives an RT to do research? Now, this project is a small component of my PhD, and I'd like to take this opportunity to thank Associate Professor Carolyn Wright, Associate Professor Georgia Halkett, and Adjunct Associate Professor Kelly Knight for sharing their skills and knowledge and providing such fantastic support. The importance of research in radiation therapy is well publicised, with research assuring high quality patient care, service delivery and consistency in standards of practice. At present, nationally, there are limited clinical research positions and few practitioners have high degree research experience. Research capacity building within radiation therapy needs to continue, and we need to determine what motivates RTs to participate in research. The allied health literature acknowledges the importance of understanding the barriers, the motivators, and the enablers when engaging in research, as it can help prioritise the research capacity building strategies. A more in-depth investigation has shown motivators are more strongly associated with research activity than barriers, and it's recommended to focus on maximising the motivators and enablers to ensure implementation of effective research capacity building strategies. To understand a little more about motivators, let's look at the two different types. Intrinsic, which is when research is done for inherent satisfaction, and extrinsic, which is when it's driven by external rewards, with enablers being a person or thing that makes something possible. In the Australian radiation therapy sphere, limited work has been done on motivators, with the study by Canadian RTs identifying intrinsic motivators as self-motivation, self-inquiry, curiosity, and satisfaction collaborating. More extensive work has been completed on enablers in both Australia and Canada, with mentorship and a structured approach to participating in research as stronger enablers than educational initiatives such as research education workshops and in-services. Whilst this information is helpful, its application to the clinical setting is broad, and further work is needed to be completed in regards to determining how they relate to the various clinical settings. The aim of this presentation was to investigate the motivators and enablers for RTs to participate in research in relation to the proportion of research within an individual's role, work location, and health sector. To measure the research capacity of the RTs practicing within Australia, which includes motivators and enablers, a cross-sectional survey with both quantitative and qualitative items was chosen. The RCCT was considered the most suitable tool, as it had been validated within Australia and used by several other allied health professions within Australia. Each item was measured on the participant's self-report. The survey consisted of 4 components: organisation, department, individual, as well as demographic information. For the purpose of this research aim, we'll focus on the quantitative responses from the individual and demographic sections. The survey collected a vast amount of demographic data. However, our focus for this project is current work role, experience, present employment, and age. Ethics approval was received in September 2020, and the RCCT was circulated during the month of October by professional groups and networks, including the ANZMRRN. The invitation, email, tweet, and Facebook posts contained website links directed to the participant information sheet and online survey. By completing the survey, consent was implied. The survey was conducted using Qualtrics, and the completed data was exported to SPSS for analysis. The survey had a completion rate of 68%, with 121 RTs completing the survey in its entirety. The survey responses represented 4.8% of the Australian population. The age groups were represented, with the majority of the working population in that 35 to 44 year age bracket. Overall, there was noticeably more participants working at metropolitan centres, with 100 compared to 21 at rural regional centres, and 104 participants in public sector compared to 17 from the private sector. We were fortunate to capture responses from all role classifications. The clinical practitioners were highest, making up 47 of the 122 participants, followed by team leaders and management staff. On closer examination, it was interesting to note minimal or no response from the rural regional sector in regards to roles that incorporated research, for example, advanced practice roles, research coordinator, and clinical trial coordinator research roles. This was also reflected in the private practice. Looking at the proportion of research within a participant's role, 25.4% had no research within their role. Nearly half of the participants had less than 10%, with only 26.3% having greater than 10% in their role. Tertiary and research institutions had the highest percent of RTs in the greater than 10% category, and rural and regional and private had the least staff in the greater than 50% category. The motivators and enablers are presented in overall rank. The initial question had 17 motivators. However, today I'm just going to discuss the ones that are of most interest. The highest ranked research motivators of participants in the greater than 10% category were developed skills, increased job satisfaction, and clinical problems identified that needed changing, with grant funds and study or research scholarships ranked lowest. The greater than 50% category had increased job satisfaction, markedly higher than the other motivators, and they also ranked having research written into their role higher than the less than 50% category. This project has allowed us to establish what motivates RTs to participate in research and the enablers that are presently available in the clinical setting in regards to proportion of research within their role. The proportion of research within a clinician's job description can have a positive influence on an individual's research capacity, with a study of Queensland dietitians showing that if you have over 10% of research within your role, you had a higher research skill and success level. RTs recorded similar results to Queensland dietitians. In regards to work location and health sector, RTs employed in private sector recorded the lowest proportion of research within their role, which reflects the results found by Australian podiatrists. Whilst this is helpful to see we align with other allied health professionals, we still need to determine the number of staff within an organisation that should have research within their job description and drive research. The three highest ranked motivators of Australian radiation therapists were reflected within the literature by other allied health groups and the wider MRS community. The higher ranking motivators were intrinsic, which does infer research capacity building strategies need to be targeted to RTs that are intrinsically motivated first to have the largest benefit to the Australian radiation therapy profession. The greater than 50% category found having research within their role was a markedly higher motivator than those with less than 50%, which could be confirmation having greater than 50% of research within your role could be an appropriate amount that is conducive to motivating RTs to participate in research. Limitations to this study include the number of participants. It does, however, represent the demographic makeup of radiation therapists. The only other allied health discipline that has completed a national RCCT survey was podiatry, that registered a 6% representation of the population, which is slightly higher. The RT population sampled could also have an invested interest in research, so we need to be cautious in generalising these results across the entire RT profession. This study has identified the motivators and enablers of research for Australian RTs that should be incorporated into future research capacity building strategies. By maximising RTs' exposure to the identified motivators and enablers and targeting RTs that are intrinsically motivated, the greatest benefit from research capacity initiatives can be achieved. Where to from here? Well, as mentioned previously, this project is a formative component of my PhD. Phase 1 of the project was the RCCT. Additional to this presentation, we have further analysed the survey data with a particular focus on areas that would benefit from research capacity building interventions in regards to workplace and health sector. The results of phase 1 informed phase 2 of the project, that it is a qualitative study adopting a constructivist grounded theory methodology to further understand the factors that surround the transition from clinician to clinician researcher. 31 one-hour semi-structured interviews have been completed during a 3-month period with a self-nominated participant, and an analysis of these interviews are nearly complete. Based on the outcomes of the analysis, phase 3 will be determined. As you can see by the brackets, the dissemination of this information will take the form of several papers additional to the presentations I have completed thus far. I would like to thank the RT community that have continued to support this project. It was so inspiring for me to see more recently the 30+ RT volunteers that gave their time so willingly for the interviews. I would also like to thank ANZMRRN for the funding opportunity and the ANZMRRN, amongst others, that distributed the survey to my RT colleagues. It has been greatly appreciated. That's it from me.
Thank you so much, Rachel.
Thanks, Peter.
I'll get you to stop sharing your slides and I'll ask Peter to share his screen. Okay, while Peter sets up, Peter's a diagnostic radiography student at the University of Sydney. He's in the first year of his honours. We have honours that runs over 3 semesters, and he is a tennis player, but he's also interested in researching in tennis for tennis players. And he's looking at foot and ankle injuries in tennis players, morphology and function of the intrinsic foot muscle, and he's supervised by Associate Professor Julian Clark.
Great, thanks for that intro, Peter. Good evening, everyone. My name is Peter Hanna, and I'm a 3rd year diagnostic radiography honours student at the University of Sydney. And as Peter said, tonight I'll be presenting on foot and ankle injuries in tennis players, morphology and function of the intrinsic foot muscles. So as a bit of an introduction, the International Tennis Federation's 2021 Global Tennis Report told us that a staggering 87 million people worldwide play tennis. However, Kemmler et al. Noted that as the number of tennis players increases, so does the number of reported foot and ankle injuries. The impact of these injuries has become of particular interest, as they are reported to be the most common severe injuries in tennis players, with an increasing body of literature surrounding the significance of the intrinsic foot muscles in these injuries. Thus, a significant issue for exploration is the impact of these foot and ankle injuries on the intrinsic foot muscles of tennis players. By understanding this, a more detailed and accurate management plan for performance optimization, injury prevention, and therapy in both recreational and advanced tennis players can be developed. Therefore, the purpose of this study is to determine if there's an association between foot muscle morphology and the performance functionally of selected intrinsic foot muscles in tennis players who have experienced previous foot or ankle injuries. For some further background, ultrasound is an imaging modality that uses sound waves to produce images based on the differences in acoustic impedances of materials, making it non-invasive and non-ionizing. Whilst ultrasound is highly operator and protocol dependent, it has been proven to be a reliable and validated tool for accurately measuring and imaging the intrinsic foot muscles. Due to its image detail, ability to perform a dynamic assessment to accurately measure the correct muscle, accessibility, and cost effectiveness, ultrasound was chosen as the preferred imaging modality to answer this clinical question. When it comes to the need to develop a novel biofeedback device, Soiser et al. Note how the contribution of the extrinsic foot muscles cannot be excluded from the strength measurements of the intrinsic foot muscles. Moreover, other muscle tests that isolate the intrinsic foot muscles, such as the paper grip test, are highly operator dependent. Thus, a new biofeedback device known as the Archercise was created to quantify the performance of the intrinsic foot muscles and the arch. The Archercise system consists of an electronically controlled inflatable bladder that can measure foot arch movement through bladder pressure changes, as well as an adjustable toe and heel sensor for foot location data. Whilst this device has been validated for healthy populations, its lack of testing in populations with pathology warrants further exploration. In terms of the intrinsic foot muscles, they are a group of muscles that originate, insert, and operate within the foot itself. The function of these muscles involves maintaining the medial longitudinal arch, controlling the degree and velocity of arch deformation, aiding in postural control during stance and gait, as well as helping inversion, propulsion, and dynamic performance. Of particular interest are the flexor digitorum brevis and adductor hallucis muscles, as they aid in the contraction and for dynamic propulsion in athletic populations. It has also been shown that by exercising the intrinsic foot muscles, a positive impact on balance, foot posture, and agility can be achieved in athletic populations. A gap in the research exists when it comes to foot and ankle injuries in tennis players, as these injuries can often be overlooked in light of more familiar tennis injuries, such as that of the shoulder, elbow, and the wrist. For context, as seen in this table, Robertson et al. Note how 11.95% of their surveyed athletes reported ankle injuries, with an additional 5.58 reporting foot injuries. To further this point, in a review of all injuries at the Australian Open between 2011 and 2016, foot and ankle injuries were reported as the most frequently occurring injuries in female and male tennis players, respectively. For the ultrasound scan, the participants will be seated with their knee flexed and hip placed at 90 degrees and their foot in a neutral position. Bony landmarks will then be palpated and marked with an erasable pen to ensure accurate, reproducible measurements are taken and to reduce measurement bias and operator dependence. This is to ensure the exact anatomical region is measured as opposed to the widest or thickest element of the muscle. For the abductor hallucis muscle, the medial sesamoid bone and navicular tuberosity will be marked and palpated. The probe will be placed longitudinally to the medial sesamoid bone, and the muscle will be tracked to the navicular tuberosity. Here, the operator will ensure the probe is perpendicular to the participant's foot in contact with the region and turn the probe to 90 degrees, where the participant will then flex their first digit downwards against the operator's hand, with the movement reflected in real-time imaging. This is to ensure the correct muscle body is measured. Images will be taken in the transverse plane, and this process will be repeated 3 times, with average measurements taken for increased reliability. For the flexor digitorum brevis muscle, the probe is placed perpendicularly to the plantar aspect of the foot. The probe is then positioned to the midpoint of the true foot length, which is between the end of the first metatarsal and the end of the calcaneus. The participant will then be asked to flex the 2nd to 5th digits downwards against the operator's hand to ensure the correct muscle body is being measured. Images are required, and this process will be repeated 3 times, with average measurements taken for increased reliability. For the ultrasound device, as seen on screen, participants will be asked to perform 4 main exercises: the speed test, which is the rapid raising and lowering of the arch; the endurance test, which is holding of the raised arch; the arch elevation test, which is slowly raising the arch; and the arch lowering test, which is raising the arch and then slowly lowering it. An explanation and demonstration of each exercise will be performed before measuring, with participants being able to practice the exercise before the testing measurements occur. Each exercise will be performed 3 times, with average measurements taken to ensure reliability, with a 5-minute break provided in between exercises to recover or until the participant is ready to complete the next exercise. So for our methods and design, an observational cross-sectional study was selected as it is low cost, allows repeatability, is not time consuming, and allows for group comparisons to better enhance understanding of the data acquired. Further advantages of performing this study are that data is to be collected at a single point in time in the population, reducing the variability in muscle change over time, as well as minimizing logistical issues in traveling to the university. For our sample, this study will collect data on tennis players of both genders aged over 18 years old at 2 levels, advanced and recreational, based on the universal tennis rating metric. This will encompass players who have and have not had previous foot or ankle injuries as the sample of interest and control group respectively. This study aims to accrue a sample size of 30 using non-random purposive methods, as this is considered adequate for inferential statistical analysis based on the central limit theorem of distribution, usually defined as n is greater than or equal to 30. Similar studies regarding tennis player foot and ankle injuries have also used this as a guide. For example, Mock et al. In 2021. An injury will be defined as an event that forces a player to miss 3 or more consecutive days of tennis play, either practice or competition, or that requires medical attention from an athletic trainer, physical therapist, or doctor, with this injury affecting the foot or ankle region. The participants will need to have played tennis for longer than 12 months and have not had any previous foot or ankle surgery, pre-existing conditions affecting the region such as rheumatoid arthritis, or have trained professionally in other sports. For our data collection, participants will come to the Susan Wakefield Health Building at the University of Sydney, where they will arrive in the ultrasound room in the medical imaging suite for all the measurements to occur. The participants will complete a REDCap survey, which will consist of demographic questions such as age, weight, height, and years of tennis training, as well as further validated instruments such as the American Association of Orthopedic Surgeons Foot and Ankle Questionnaire, Foot Posture Index, and Universal Tennis Rating ranking metric will also be used. After the participant completes the survey, they will have both feet scanned using a Philips IU22 ultrasound machine with a linear array 5 to 12 megahertz transducer to take measurements of the selected intrinsic foot muscles. They will then be guided to the ultrasound device, whereby a series of gentle exercises will be explained, performed, and measurements occur. This process will be repeated for all participants. All the data will then be collated and statistical analysis will be performed to determine their significance. The variables that will be examined are the cross-sectional area in centimeters squared and the functional performance in relative pressure measures of the selected intrinsic foot muscles of each participant. The measurements will then be compared from a cohort of tennis players with previous foot or ankle injuries to a cohort without. Comparisons will also be made between tennis players of an advanced level versus those of a recreational level. By doing so, an association between the cross-sectional area and functional performance of the selected intrinsic foot muscles in tennis players who have experienced these previous foot or ankle injuries can be determined. All the data will then be analysed for normality, and intra-rater reliability measurements will be calculated through the intra-class correlation coefficient as an index of the reliability of the results. These will be paired with statistical tests such as Pearson's correlation and paired t-tests, and descriptive statistics such as gender, age, BMI, and playing history to help describe sample characteristics. In terms of looking ahead with the project, we aim to begin data collection in February and conclude in June to start statistical analysis. We plan to finalise the results by September and present the findings at the UCID Honours Symposium. The paper will then be finalised as a manuscript to be submitted to journals of interest aligning with the topic, such as the Journal of Medical Radiation Sciences as seen on screen. That concludes tonight's presentation. I hope you enjoyed it and I'm happy to discuss any questions later on in the evening. I've also put my email on screen if anyone wants further discussion out of session. Thank you very much for listening, and thank you to my supervisors, Associate Professor Julian Clark and Dr. Penelope Lately, for overlooking and assisting in the project today. Thanks.
Thanks a lot, Peter. Nice to hear the planning of this study is well underway. So next we've got Libby Arthur from Curtin University. She's finished her honours degree, and she'll be presenting on an investigation into eye gaze metrics to assess Australian professionals' chest radiograph interpretation performance, a pilot study. And Libby's coming from all the way from Europe, so thank you for taking the time to give you
yeah. Sorry, it's morning for me.
Oh.
Let me just get my slides up and figure out how to do this, maybe. This is it. Perfect. Can everybody see that one? So thank you for inviting me to talk today. This year I've conducted an investigation into using eye gaze metrics to assist chest radiograph interpretation performance, and this one was a pilot study. As is well known, image is considered one of the most difficult areas to interpret diagnostically for a myriad of reasons, but not limited, but including things such as overlying anatomy, variation in normal anatomy, as well as variation in pathology presentations. Despite this difficulty in diagnostic accuracy, there is a frequent request of chest imagery in radiography departments because of direct links to patient welfare, patient treatment options, and overall outcomes, especially considering current climates with the pandemic and COVID-19. One thing that's really interesting in the medical space at the moment is the development of eye tracking, which is a novel technique for analysing eye movement. It's founded on the concept that there is a relationship between cognitive processing and eye movements. That's physiological connection. So hypothetically, if you analyse a radiologist's eye movements, it should give an insight into what they're actually thinking at that moment in their interpretation. The way that eye tracking works is facilitated by a camera, which produces infrared light, which is then reflected off the cornea and then captured again by that camera, run through calibrations, validations, and extra algorithms to create a gaze point on the image in reference to the stimuli, which therefore creates a gaze map over time, which basically gives your eye metric data. For things such as in focusing human performance, visual search, and cognitive processing, which does tend to be more in the psychology and developmental areas, but there have been recent developments and breakthroughs into other medical fields, such as the analysis of electrocardiograms and other radiology practices, which is what we're focusing on today. So prior to the beginning of this whole pilot study, I conducted a literature review in combination with Professor Zhonghua Sun into the application of eye tracking technology in the assessment of radiology practices. So basically seeing where we're sitting in regards to the use of eye tracking in radiology. And we came up with 4 main themes, which was the competency assessment, educational reform, visual search behaviour, as well as focusing more on that competency assessment section. There was strong relationships, significant relationships between expertise and speed, expertise and accuracy, and expertise and confidence. There was, however, inconclusive results in regards to that relationship between expertise and eye metrics. this field is very, very small. So discovered that in regards to use of eye metrics in an eye analysis in radiology, there's only 25 studies from 2011 to 2022, about 25 studies, and they all vary wildly in methodology. So some will focus with different participant groups, different data sets, etc., which all make it very difficult for creating concluding statements, generalizability, and application to the clinical workforce. So considering this gap, this research gap, and especially research gap within an Australian context, and considering the current climate with the COVID-19 pandemic, we thought it was suitable to conduct this study to investigate the performance of health professionals interpreting chest radiographs using eye tracking technology. So moving on to our methodology, we got ethics approval from Curtin, which was recognised as a low-risk study, which just required written informed consent from all participants, which was achieved easily. In regards to those participants, we had radiography students, medical students, radiographers, radiologists, and another host of medical specialties, mainly focusing in that respiratory physician kind of expertise, because we're focusing on chest imagery, obviously. We had this kind of spread of health professional backgrounds just to get a good idea about what kind of interpretation techniques and developments in education, that kind of focus. In regards to our chest X-ray images, we selected 5 with some qualities. These were assessed through our research team, our individual research team, and also through an independent expert for a variation in difficulty. These were all randomized to avoid bias. So for each participant, they would have appeared in a random order, and they were as such: a lung cancer for image A, pneumothorax for image B, pulmonary edema for image C, and then we've got pulmonary tuberculosis for image D, as well as image E's atelectasis. So our equipment, this is the equipment that we used, was the Tobii Pro Spectrum hardware in combination with the Tobii Pro Lab software, as seen in this image here, the first 2 images, and the second image is more of our setup with the researcher involved. So these kind of equipment is highly suited for research purposes, with a gaze capture of up to 1200 hertz, and also has been, similar technologies have been used in various other studies within those 25 literature, those 25 articles and other research that we have touched on previously. So very suitable. We also use a radiological monitor to improve that clinical application, as well as a sound recorder to improve that sound quality, especially for accuracy and confidence measurements. So moving on to these outcome measures, we kind of focused on other studies as well. So we're trying to improve the generalizability of the field. So we did accuracy, confidence, speed, fixation duration, and time to first fixation. So it is noted within time to first fixation and fixation duration, these are both focused on that area of interest, so that area of pathology. Data analysis. We utilized a program called Jamodi with a combination of linear mixed models and generalized linear mixed models with logistical regression for our analysis. And as you can see in our graphs coming up later on. Okay. So just breezing over the results and discussing them further in discussion, we firstly tried to focus on what other studies were doing in this space. So one of our studies that we focused on was McLaughlin et al. In 2017, which is a UK study focusing on radiography specifically, and they did that kind of expertise focus on their outcome factors. So this is also kind of an example of that. So we found that there was a significant relationship between expertise and accuracy. We also included this image variable just for further exploration. So as you can see, the blue, which is the experts, are consistently more accurate with students. We would hope to expect this, which has a p-value of 0.015. Moving on, interestingly, however, there was a non-significance between expertise and fixation duration, as demonstrated in this graph. This, however, with the inclusion of an image variable, this further explains this non-significance, because you can see that the experts and the student focuses in this AO are all over the place. I'll discuss this further, but it's just very interesting when you're considering the further explanation of these data points and their significance. From here, we decided to use a more exploratory focus and actually investigate the influence of outcome factors and impacts on your actual diagnostic performance and accuracy. So here, unsurprisingly, we've got a relationship between diagnostic accuracy and image presentation with a p-value of 0.002. Additionally, we've got a strong significant relationship between accuracy and duration, which is very interesting, with a p-value of 0.006. It's very interesting to note also here, if I can point with my mouse, very interesting that we've got a plateau here at about the 60 to 80 second mark in regards to that kind of accuracy rating. As well, the last significant result that we found was that result between accuracy and confidence, which demonstrates with a p-value of 0.001. Interestingly, for our non-significant relationships that we found is that kind of relationship between time to first fixation and accuracy, as well as that interpretation speed and accuracy as well. So that's just very interesting to consider for later on. Lastly, the one thing I want to touch on, which I can't really comment on significantly, is the production of heat maps. So Toby, the software, produces these heat maps, which show red areas being that kind of more higher fixation region and green being that less. Whilst I can't comment on it for a clinical application or statistically without bias at the moment, it is just very interesting to see how different areas and different professionals actually change their focus of interpretation across the same image. It's just fascinating to me. I'll have to look at it later on. So key findings, just want to touch on this briefly. The key findings is that the expertise measurements, the influences of expertise on the outcome measures is pretty much similar to what we have and reinforces other studies. We have investigated impacts on accuracy measurements, and this is one of the first studies to kind of focus on that accuracy within this iMetric space, as well as some conflicting non-significant results. So this expertise and accuracy relationship, its experts are significantly more accurate than students. We would hope so. This is mimicked in a whole bunch of other studies, which is outlined in the literature review if you'd like to go and read it. But it's very expected, and it's good to reinforce that kind of previous literature as well. Interestingly for me, in this kind of expertise space, is this relationship between expertise and fixation duration. So this demonstrates a non-significant relationship, and this is also in line with the other literature that has kind of discussed this topic already. So as you can see here, if my mouse is coming up, you've got image A, the experts are going to focus more on that lung tumor region in comparison to students, but then the opposite is the same. Can be said the opposite, where students focus more on the pulmonary edema area than the experts. So it's just very interesting. I can't comment on the methodology. I can't say why, but it's just very, very interesting, and especially considering the lack of literature in this area, and actually using that kind of image presentation as a variable within this kind of discussion of non-significance. Moving on to a more exploratory focus, we kind of looked at image and accuracy. Unsurprising considering the previous studies. Image type has a considerable impact on professional performance. Again, unable to comment on the methodology of why, but there is some literature that does support such data. It's just very interesting and important for future research. Additionally, the relationship between confidence and accuracy. This is kind of supported by literature with Crow, McLaughlin, and Wood. So in that literature review, which states a higher expertise level contributes to a higher degree of professional confidence. Now, we focused on accuracy and confidence, but this kind of supporting literature with expertise kind of allows for a supporting hypothesis to be generated. And so that we can hypothesize that if you're going to be more professionally confident, you're going to have a higher degree of accuracy, which is understandable. However, we have to be cautious of overconfidence and underconfidence, which is a phenomenon that we have to be careful of when considering like application in the clinical space and as a measure of competency. One more point on this fixation duration business. This one was really interesting to me because we found that there was a longer time spent fixating on the area in the chest radiograph, the greater the diagnostic accuracy rate. So this is interesting considering other literature, which some produce positive relationships, some produce negative, and some produce non-significant. So it is adding to that kind of discussion on the variation in literature, but we have to remember that all of the studies have incredibly different methodologies. So it's just, it's have to keep that in mind. But it is definitely interesting when you're considering radiological application and to the clinical workplace and radiologist work. Moving on to that conflicting kind of, we found that there was no significant relationship between accuracy and time to first fixation, which has been kind of, there's other literature which suggests the opposite. So that like van der Jip, which suggests that like a positive relationship. But if you're faster, time to first fixation correlates on a higher degree of accuracy. We are unsure if this is due to the limitations or the different perspective in that we're focusing on accuracy rather than that focusing on that level of expertise. And the kind of a similar situation with interpretation speed. So we found in our literature review that there was a weak positive relationship between a faster interpretation speed and an expertise level. However, we found a non-significant relationship in this study. So again, this is the implication whether this speed is influenced by expertise only and not by diagnostic accuracy. Again, something that needs to be further investigated. So limitations, there were quite a few, mainly surrounding the fact that this was a pilot study. So things such as our sample size restricted by COVID and participant professional engagement. So we tried to move the setting halfway through the study to improve engagement. But again, we were limited in our kind of participants. Again, data set size. So we only had 5 images. Increasing that data set would obviously increase your data volume, reliability, validity, etc. Interestingly, talking about the pixel restriction is that we utilized images from an online repository which did produce the images in a JPEG, and it is important to consider that most of the application of radiological interpretation is done, which does have more information, more radiological information. So it's just important to consider in further studies, which we're kind of thinking about doing, like expanding this project. It would be more applicable to use DICOM images. It was just suitable for a pilot level study in this year, but it's definitely important to consider and a limitation that we have to recognize. As well, was a research of presence required, which does kind of suggest like an exam kind of situation for that participant, which may hinder results, but it is important to maintain that data quality, which can vary. And it's important to recognize that it varies dependent on participant, operator, situation, setting, lighting, all of the above, and just general error. So it's just important to consider that as well. Conclusions. This study basically reinforces relationships between expertise and outcome factors. So it reflects current studies, it reflects current literature, but it also adds that additional kind of analysis and understanding, especially that non-significance, especially with that image type and presentation. And it is also one of the first studies of its kind to analyze the relationships between accuracy and outcome factors and income factors with that kind of I-metric slant. Areas of further development, of course, this is a pilot study. We would love to improve generalizability, improve your data set size and everything like that, so it's more suitable for clinical application, further exploration of the outcome factors. One note that was important, involvement of additional material. So in this case, we didn't use any patient history of the like. So this would be interesting for an additional analysis, and as well as qualitative analysis for evaluation of verbal cues and the like, as well as those heat maps. Very interesting. I'd love to explore that further. So I just want to acknowledge all of my supervisors and people that have helped out with this study. There's been invaluable support for this project, and I hope that it goes to the future, which is exciting. So thank you.
Thank you very much, Elizabeth. Can I get you to stop sharing your screen? I'll ask the other presenters to also put their cameras on and their mics on, and we'll open up for any questions. So feel free, if you're in the audience, you can turn your microphone and ask the question. I've got a couple of questions here myself, but I'd welcome questions from the audience. Sharon, did you have a question?
Oh, there's one on the chat, Peter.
Oh, great, thank you.
Yeah, just from Jill Clark.
Hi, Jill. Thanks for your question. Actually, I found the eye tracker one of the best things about this experiment. The participants collecting the data was all crazy with COVID and stuff. The eye tracker itself was fantastic. I was really fortunate to have a researcher who'd also conducted an experiment with the same equipment for a pediatric study in another area. So she was actually really invaluable. That was Dr. Melissa Black. She helped me out with a lot of technical issues that I did have initially. And once I kind of created the experiment, it was quite easy to run. A lot of issues that I did have with the technology was not the eye tracker's fault. It was primarily mine. So I think if I can recommend anything, the kind of equipment that I did use, which was the Tobii Pro Spectrum, was really user-friendly. I really, really enjoyed using it actually, and I would highly rate it.
Thanks, Elizabeth. I should tell those people who don't have access to the chat. Jill says that in the past we've had experience with eye trackers and they've been notoriously difficult to get working. So sounds like Elizabeth didn't have those kind of problems with the eye tracker that she was using. And I imagine with time, the technology gets better. Any other questions? Philippa, I've got a question for you. So is the incidence of tuberculosis in South Africa still quite high? Is this something that requires a lot of medical management, and that's why this type of study is so important?
Yeah, it is still very high, and unfortunately with the pandemic, what happened was our patients became too scared to come to the hospital. So what ended up being I don't want to say just tuberculosis, but they ended up having a whole host of other things happening to them because of that initial diagnosis that wasn't made, or they were too scared to come. So that then made the initial treatment plan is already 6 months. We know TB patients are really bad at keeping to their treatment because they start feeling better and then they stop the medication. And then we get all the multi-drug resistant strains. So for us to be able to identify the patients who would not respond well to the standard regimen at quite an early stage in their treatment would be really great to just change their treatment path without them having to go through the 6 months, fail, go through it again. You know, it's just this repetitive cycle. So it is still a huge problem. But yeah, there's a lot of studies ongoing to try and develop and establish these host-directed therapies that are more effective than the standard one fits all.
Thanks so much, Pippa. Any other questions from the audience? I do have more questions myself, but I'm more than happy to take questions from others. Peter, I have a question for you. What was the actual units that you're measuring with the ultrasound? Was it volume? Was it length? How did you determine through your measurements whether you're looking at normal conditions or abnormal conditions?
Thanks for the question. It was foot muscle volume, which is measured in centimeters squared, because that's been a validated kind of way of measuring the standardized function, or the standardized morphology of the muscle. There have been other studies that have used ultrasound measurements to measure like the standardized benchmarks for the abductor hallucis and flexor digitorum brevis muscles in research regarding chronic ankle instability and diabetic patients. So it's kind of following on from that field of research and allows us to set like a benchmark in our own measurements, where we anticipate that those who have had foot or ankle injuries will have like a lower muscle volume in centimeters squared, as well as reduced pressure measures of strength and endurance on the archercise system.
So Peter, you're saying that if you've had an injury, the actual muscle volume becomes less, is that correct?
Yeah, that's why we hypothesize.
And I guess because it's a single cross-sectional measure, positioning must be really important. You must get it into the same position every time for every patient, is that right?
Yeah, so we've put like great emphasis on using bony landmarks and reproducible protocols that can be implemented numerous times. So, for example, for the abductor hallucis, starting at the medial sesamoid bone and tracking it back under the navicular tuberosity, doing that 3 times and then averaging the measurements. That way we can kind of set a benchmark for that, as well as doing the same for the flexor digitorum brevis muscle, using the true foot length as opposed to just scanning and trying to find the biggest part of the muscle, because that may not be a true reflection of the morphology of the muscle at its kind of greatest point.
Great, thanks for your answer, Peter. Rachel, can I ask you a question?
You can.
Rachel, so congratulations on the grant. How did it help with your research? That's my first question. The other question is, how do you target those interested in research? How are you going to find those people?
So in regards to the grant, it was able to help me with my phase 2. In regards to the interviews, I was able to engage with a research assistant who could do not all but most of the interviews, and she also cleaned those transcripts. I also was able to fund someone to transcribe. So the $10,000 from ANZMRRN covered the 30 interviews plus the transcriber, and also the 3 $50 My gift cards for the lucky participants. So that was so helpful, because I think it enticed people to do it, that people were very passionate, obviously, about it, but also it took a load off because the research assistant was able to coordinate the interviews, and they were done within 2.5, 3 months, which was fantastic. And I also got experience doing some interviews and getting feedback from her as well, which is good.
So it sounds like it's sped up your research and saved you a tremendous amount of time having that type of assistance.
Yeah, no, it certainly did. Yeah, no, it certainly did. And sorry, your second part of the question was?
Oh, it was a bit tough asking you 2 at once. The other one was, you talked about how important it was to target people who are interested in research. Yep. So putting your energies into those who want to develop a new skill or want to ask a research chat question and make a change. How would you target those people? How should we find those people in IT?
What we've done is, as part of the other components to that phase 1, we were able to look at a research analysis plan, which is actually in a methods paper that I'm trying to get published at the moment. And it allowed us to look into the different health sectors and workplaces and isolate those people and what percentage of those people need that help. So we can then focus our research capacity building strategies on promotion and advertising more in some areas and workplaces than others. So that's probably where that information will go. And we know the benefit of targeting, say, the rural regional areas in latest work that I've done. It is not a huge benefit compared to metropolitan. Rural and regional actually go quite a lot better. But if I was to target a private practice, I'd have a 2.1 percent fold increase. You know what I mean? So it really does show you where to hone in. Yeah.
Thanks so much, Rachel. I'll just open the floor to any final questions. Just have a look on the chat to see if anything's there as well.
Rachel,
yes.
Are you going to do any more interviews, or have you kept it at the 31?
We have kept it at the 31, and I have to say I'm halfway through the analysis at the moment, and the data is so rich. There's so much there. My mind map is like crazy. So
that's good. Yeah.
Yeah, so I probably will cap it at that. But then phase 3 may involve more interviews. I'm not quite sure just yet. I'm just getting my head around that data.
Right. Excellent.
Okay, I think we've got time for one last question. Well, if there's no further questions, I'd like to thank all the presenters for taking their time and sharing their planned research or the results of their previous research with us tonight. And I found it a really interesting series of talks and of excellent quality. So thanks again for putting the preparation in and presenting tonight. And we will share this video with other members of the Society via our YouTube channel. So till next time, thanks for joining us, and thanks for those people who came online to listen as well. Good night.
Thanks, Peter.